Assalamu alaikum, my name is Abir and my roll number is BB165007. The topic that I'm presenting is acetyl salicylic acid. Course number is PhD 705. What is acetyl salicylic acid? Aspirin is a generic name for acetyl salicylic acid and it is thought to be as a traditional NSAID, as it exhibits the anti-inflammatory activity at a relatively high doses that are rarely used. Aspirin is a prototype of the salicylates and other NSAIDs, and it is often differentiated from other NSAIDs due to its mechanism of action. The mechanism of action of aspirin is that it is a weak organic acid that irreversibly acetylates cyclooxygenase. The irreversible action of aspirin results in a longer duration of its antiplatelet effect, and as aspirin inhibits both the cyclooxygenase isoform, thereby reducing the prostaglandin and the thromboxane synthesis throughout the body. As aspirin is irreversible inhibitor of cyclooxygenase, other NSAIDs are reversible inhibitor of cyclooxygenase. The indication of acetyl salicylic acid consists of its anti-inflammatory and analgesic uses for the treatment of osteoarthritis, gout, or rheumatoid arthritis. The antipyretic effect of aspirin is used to treat fever, whereas in cardiovascular application, aspirin is used to inhibit the platelet aggregation. The low doses of aspirin, consisting of commonly 81 mg per day, is used prophylactically to reduce the risk of concurrent cardiovascular events or even death in patients with the previous MI or angina pectoris, or it is also used in a patient with chronic stable angina or diabetes. It reduces the risk of recurrent transient ischemic attacks or strokes in a patient who have had a previous TIA or stroke. The adverse effect of aspirin consists of hypersensitivity, intracerebral hemorrhage, and Reye syndrome. Aspirin should be not taken in patients who are less than 20 years old with a viral infection, that is, the chickenpox or influenza, in order to prevent the Reye syndrome. In a chart given below, there is a further side effects of aspirin. In the irrational use of acetyl salicylic acid, it consists of the gastrointestinal and increased risk bleeding that is due to its antiplatelet effect. Due to the regular use of aspirin that is associated with the gastrointestinal bleeding, the risk appears to be more strongly related to the dose than duration of the aspirin use. The daily use of aspirin also increases the risk of developing stomach ulcer. The patient who uses aspirin for the cardioprotection should avoid the concomitant NSAID use if possible. At the high doses of aspirin, it may occur that a person may experience tinnitus, vertigo, hyperventilation, respiratory alkalosis. Even the drug may cause the metabolic acidosis, dehydration, collapse, hypothermia, coma, or even death. The drug interaction of aspirin is the salicylate is roughly 80 to 90% plasma bond protein, such as albumin, and can be displaced from protein binding sites that results in increased concentration of free salicylate. So the aspirin can displace other highly bound protein drugs such as warfarin, phenytoin, valproic acid. They all result in the higher free concentration of these agents. So in this chart, there is an answer such as ibuprofen and aspirin drug interaction example given below. The toxicity of aspirin consists of the gastric ulceration, upper gastrointestinal bleeding, and renal effect that are acute failure and intestinal nephritis. When the prostaglandin synthesis is inhibited by even the lower doses of aspirin, person that takes aspirin experiences hypersensitivity, also experience the asthma from the increased synthesis of leukotrienes. Again, a children or a person who is less than 20 should take aspirin with cautions in experiencing the viral infections such as chickenpox, in order not to develop the Reye syndrome, as there is no specific antidote for aspirin. The alternative of aspirin consists of clopidogrel, that is antiplatelet drugs such as like aspirin, and it is used to prevent the thrombotic complication in a patient with a history of MI. It is well tolerated than aspirin and slightly more effective. Ibuprofen is chemically similar and functionally similar with regular aspirin. Ibuprofen seems to irritate esophagus and stomach lining less than aspirin and naproxen. Trisalicylate, like aspirin, they both relieve pain and reduce inflammation, but they are less likely than aspirin to damage your stomach or even trigger the excessive bleeding. The alternative brand of aspirin consists of aspirin dispersible, that is manufactured by Europharm International, and the trade price is 255 rupees, whereas aspirin soluble is manufactured by Navapsan Laboratories and its trade price is 102 rupees. Aspro, that is manufactured by Reckitt Benckiser, Pakistan, and its trade price is 16.16 rupees. The available dosage form of aspirin are in tablet, delayed release tablet, chewable tablets, suppositories, and intravenous aspirin. This is available in 250 mg to 500 mg. Suppository has been preferred in a patient who are experiencing nausea, vomiting, or even in the elderly patients, whereas IV aspirin road is beneficial for patients with ACS. Aspirin may be less effective than when given intravenous than in the oral administration, as the IV administration negates the differential effect of the oral administration on the platelet or the systemic endothelial cell by exposing the systemic endothelial cell to the higher aspirin concentration. The dose adjustment of aspirin in the pregnant women and pediatric is of importance, as the low aspirin dose of 81 mg per day is given in women at a very high risk of preeclampsia prophylaxically and should be initiated between the 12 week to 28 week of gestation, and it should be continued daily until delivery. For analgesic action, and in fact, infants, children, and adolescents that are weighing less than 50 kg, 10 to 15 mg per kg per dose every 4 to 6 hours, with a maximum daily dose of 90 mg per kg per day or 4000 mg per day is given. While for the analgesic effect in children who are less than 12 years old or who are weighing more than 50 kg, 325 to 650 mg every 4 to 6 hours with a maximum dose of 4000 mg per day is given. In the case study, we have a patient who is male, 50 years old. He is experiencing vague chest pain that is present at the center of the chest. The pain is located in a substernal location and it is radiating to the right side of the shoulder. And it is accompanied by dull aching pain, and it is increasing rapidly over few hours. The chest pain is aggravating by exertion, and there is a profuse sweating associated with chest pain and a sense of doom or impending death. He is also experiencing mild dyspnea and palpitation. He also takes mixed diet, smoked 1 packet of cigarette per day for the last 15 years. He has no history of alcohol or illicit drug abuse or no history of medication. He has not been taking any cardiotoxic drugs, or this patient is not known for diabetes or hypertensive, and he has no history of tuberculosis or bronchial asthma. There is no symptoms of fever, joint pain, or involuntary movement rash or nodules. So we conclude that the chief complaint is the acute onset due to external chest pain of 3 hours duration. as the pain is consists of dull aching with profuse sweating, and he is also experiencing mild dyspnea and palpitation, and the pain is increasing in severity rapidly over a few hours. We also conclude that in the past history, he is not diabetes, hypertensive, or there is no signs or history of fever, joint pain, involuntary movement, rashes, or nodules. No history of tuberculosis, bronchial asthma in the past, and he has no past surgical history. In the treatment history, we know that he has not been taking any medication or any cardiotoxic drugs. So in the objective, we have the physical examination consists of height, that is 154 centimeter. His weight consists of 70 kg. He is a patient who has average build, and he is conscious, oriented, and he is anxious at rest. There is no signs of cyanosis or edema, and there is no marker of arteriosclerosis or congenital heart disease. His vital consists of pulse rate, that is 120 per minute, that's indicating tachycardia with regular rhymes. Respiratory rate is 34 per minute. Shallow rapid breathing. ECG is showing ST elevation in anterior precordial leads V1 to V6 and also in lead 1 and 2. So our assessment is that our patient who is experiencing this chronic smoking history, who has this chronic smoking history and experiencing this chest pain at the retrosternal side, and has been experiencing it for 3 hours duration. The pain is delaying and above mentioned symptoms. So we conclude that this condition are suggestive of typical angina pain, most likely due to the acute coronary syndrome. And in ECG, we also see that ST segment elevation in the anterior wall suggests that our hypothesis of acute coronary syndrome with ST segment elevation. So in our differential diagnosis, we also see that he may have mild pulmonary embolism or aortic dissection. So our plan consists of pharmacological therapy and non-pharmacological therapy. In the pharmacological therapy, following the diagnosis of ACS, we give antiplatelet therapy to reduce the acute and ischemic complication and recurrent atherothrombotic events. It is considered of aspirin 75 mg once daily, and it is considered as a mainstay in an ACS patient. We also give P2Y12 receptor inhibitor with aspirin in a low doses, which result in a better outcome. It also reduces the incidence of cardiovascular death, MI, and stroke. Ticagrelor, which is 80 mg once daily at a bedtime, followed by the daily maintenance dose of up to 12 months. It is prescribed together with a low dose aspirin. Whereas statin consists of atorvastatin, a 40 to 80 mg once daily at a bedtime is given in order to reduce the LDL cholesterol by more than 50%, which improves the endothelial function and reduces the inflammation and also increases the platelet plaque stability. So in our non-pharmacological treatment, we educate the patient about the risk factors that are involved in this disease and about the danger of the cigarette smoking. We also educate him about the exercise routine that should be maintained and about the health diet and the benefits of the low cholesterol and low salt diet. We also further take notes that in the maintenance dose of aspirin higher than 160 mg per daily is associated with increased risk of bleeding and with no clear improvement in outcomes. While also taking atorvastatin, avoid high-fat diet or high cholesterol food as part of your overall treatment. ECG is an important in the diagnostic, prognostic, and therapeutic approach and must be obtained within the 10 minutes after the presentation of the patient with the ongoing chest pain. The serial ECG is indicated in order not to exclude the possibility of ACS, and it is also increases its sensitivity and helps in differentiating between the acute and the chronic alteration. Here are the references which have been used to make this presentation, and thank you.